Beware, 9 popular medications that can trigger rapid dementia after 60. The story of Margaret, a vibrant 68-year-old woman, serves as a stark warning about the invisible dangers lurking in many medicine cabinets. Margaret was renowned within her family for her sharp mind, her ability to recall every birthday, and her daily conquest of the morning crossword, earning her the affectionate title of the human Google of the household. Yet, this mental acuity began to crumble approximately 18 months after her physician added a new prescription to her daily regimen. Her daughter, distraught and confused, called me to report a series of alarming cognitive changes. Margaret was unable to remember her breakfast just hours later, struggled to navigate familiar routes home from the grocery store she had frequented for 2 decades, and repeated questions 3 times within a single conversation. Her neurologist, seeing the classic markers of forgetfulness and disorientation, suspected early Alzheimer's disease, leaving her family devastated and preparing for the long, painful decline associated with neurodegeneration. However, what no one had initially recognized was that Margaret's dementia-like symptoms were not caused by Alzheimer's. They were caused by her medicine cabinet, a phenomenon known as drug-induced cognitive decline. When we systematically reviewed her medications and made strategic adjustments under her physician's supervision, Margaret began to emerge from the cognitive fog. Within 4 months, she was once again solving complex crosswords, demonstrating that her condition was not irreversible degeneration, but rather preventable medicine. This remarkable recovery highlights a critical point. Certain common medications can quietly and invisibly steal memory by interfering with the brain's delicate chemical balance. We must examine the 9 most common culprits, ranked from commonly overlooked to the most dangerous combination that often goes completely unrecognized by medical professionals. This information is crucial for anyone over 60, as silence and unawareness can accelerate cognitive decline. Before delving into specifics, it's essential to understand that this is not medical advice to abruptly discontinue any medication, which can be dangerous. Rather, it is information empowering patients to ask questions, understand the substances entering their bodies, and advocate for their brain health. Medication number 9 on this list is diphenhydramine, commonly sold as Benadryl, and present in a vast array of over-the-counter sleep aids and nighttime relief products. Many people assume these products are harmless because they are easily accessible and labeled as sleep solutions. However, a significant danger lurks within this common pink pill, particularly for individuals over 60. Diphenhydramine belongs to a class of drugs called anticholinergics. This classification is critical because anticholinergics work by blocking acetylcholine, the brain's primary neurotransmitter responsible for memory formation, focus, attention, and staying alert. While younger individuals typically have ample acetylcholine to compensate for this blocking action, the aging brain operates with lower baseline levels, making it highly susceptible to the effects of anticholinergics. The nightly use of diphenhydramine, even in seemingly small doses, can significantly exacerbate this vulnerability. A landmark study in the Journal of the American Geriatric Society demonstrated a substantial increase in cognitive decline risk among older adults who regularly use diphenhydramine, noting measurable shrinkage in memory-related brain regions in neuroimaging studies. The insidious nature of diphenhydramine lies in its concealment within dozens of products labeled PM, nighttime relief, or sleep formula, often without a patient realizing they are taking an antihistamine. Instead of relying on these anticholinergic sleep aids, safer alternatives for allergies include second-generation antihistamines like loratadine, Claritin, or cetirizine, Zyrtec, which do not cross the blood-brain barrier as easily and therefore avoid interfering with central nervous system function. For sleep, non-pharmacological interventions or other safer alternatives should always be explored first. Medication number 8 concerns proton pump inhibitors, PPIs, a category that includes common drugs like Prilosec, omeprazole, and Prevacid, lansoprazole. These medications are among the most overprescribed drugs globally, designed to reduce stomach acid to manage acid reflux. The primary issue is not the medication itself, but rather its indefinite use. Most PPIs were initially designed for short-term therapy, typically 8 to 12 weeks, yet many patients remain on them for years without re-evaluation or attempts to taper off. This long-term use presents a critical risk to brain health because stomach acid plays a vital role in extracting and absorbing vitamin B12 from food. Vitamin B12 is non-negotiable for neurological function. A deficiency can lead to memory impairment, nerve damage, depression, and a specific pattern of cognitive decline that closely mimics early Alzheimer's disease, frequently confusing even experienced physicians. Beyond B12 absorption, research has pointed to an even more alarming potential mechanism. PPIs may accelerate the accumulation of amyloid beta plaques, the toxic protein buildups that characterize Alzheimer's disease. A 2016 study in JAMA Neurology examining over 73,000 adults found that long-term PPI users faced a 44% higher risk of developing dementia compared to non-users. A strategy to mitigate this risk involves working with a physician to taper off PPIs using H2 blockers like famotidine or Pepcid as a temporary bridge. Lifestyle adjustments such as eating smaller meals, avoiding late-night eating, and slightly elevating the head of the bed can dramatically reduce reflux symptoms naturally. For those requiring long-term PPI therapy for genuine medical needs, regular testing of B12 and magnesium levels, often requiring supplementation, is essential to mitigate deficiencies. Medication number 7, bladder control medications, presents another clear danger due to anticholinergic properties. Overactive bladder, OAB, and incontinence are highly disruptive and embarrassing conditions that significantly diminish quality of life, leading many patients to readily accept a prescription for drugs like oxybutynin, ditropan. The problem, however, lies in what is often not explained to the patient. Oxybutynin is one of the strongest anticholinergic medications in common clinical practice. It does not limit its effects to the bladder. It easily crosses the blood-brain barrier and directly interferes with the same acetylcholine systems crucial for memory and learning. Studies have demonstrated a measurable reduction in hippocampal volume, the brain's central processing center for memory, in long-term anticholinergic users. A comprehensive 2019 study published in the British Medical Journal found that seniors using potent anticholinergic medications like oxybutynin for more than a year experienced a 49% higher risk of dementia diagnosis. What makes this particularly tragic is that the early cognitive symptoms, such as misplacing objects or struggling to find words, are almost universally dismissed as just getting older, diverting attention from the true cause. The medication itself is rarely questioned. Fortunately, newer bladder medications like mirabegron, Myrbetriq, work through a different mechanism, beta-3 adrenergic agonism, that carries a dramatically lower cognitive risk. Patients taking oxybutynin should initiate a conversation with their physician about a possible transition to these safer alternatives if mental changes are observed. Medication number 6 covers benzodiazepines, benzos, a class of drugs frequently used to manage severe anxiety, panic attacks, and sleep disorders like insomnia. For individuals experiencing acute distress, benzos can feel like a necessary lifeline. However, the science clearly indicates significant risks associated with long-term use, especially in older adults. Benzodiazepines work by amplifying GABA, gamma-aminobutyric acid, the brain's primary inhibitory neurotransmitter, or calm down signal. While highly effective in producing short-term relief, the chronic over-amplification of GABA for months or years leads to neural changes where the brain reduces its natural activity in response. This results in the deterioration of neuroplasticity, the brain's ability to form new connections and adapt. Memory encoding slows, executive function weakens, and emotional regulation falters. A 2022 study tracking over 8,000 seniors over 6 years found that those using benzodiazepines for more than 3 months had a 51% increased risk of Alzheimer's disease. The risk was particularly high for long-acting formulations that accumulate in fatty tissues, including brain tissue. The major trap with benzos is the brutal withdrawal process. Rebound anxiety and insomnia are often far worse than the original symptoms, making patients believe they cannot function without the drug, even as it causes cognitive decline. Never stop benzodiazepines abruptly, as this can lead to dangerous medical consequences, including seizures. Instead, work with a physician on a slow, carefully supervised tapering schedule over weeks or months. Alternatives include buspirone for anxiety and cognitive behavioral therapy for insomnia, CBTI, along with low-dose melatonin or magnesium glycinate. Medication number 5 is statins, a category that requires careful consideration because these drugs genuinely save lives by reducing cardiovascular events. For many patients, statins are appropriate and necessary to prevent heart disease, which remains the leading killer of people over 60. However, a less discussed aspect of statin use relates to brain health. The brain is composed of nearly 60% fat, making cholesterol a critical structural component, not just a villain. Cholesterol forms the myelin sheath, the protective insulating layer around nerve fibers that ensures rapid and efficient signal transmission. It is also essential for synapse formation, enabling neurons to communicate. When systemic cholesterol is aggressively lowered with a statin, there is a risk of depleting the brain of necessary building blocks for maintaining its architecture. The FDA recognized this risk in 2012 by updating statin labeling to include warnings about memory loss and confusion as potential side effects, an acknowledgement based on thousands of adverse event reports. A 2023 analysis published in Frontiers in Aging. Neuroscience found that seniors over 70 using high-dose statins for more than 3 consecutive years showed a measurable increase in mild cognitive impairment compared to non-users. The nuance here is crucial. Not all statins present equal cognitive risks. Lipophilic statins, such as simvastatin and atorvastatin, readily cross the blood-brain barrier and are associated with a greater cognitive impact. Hydrophilic statins, like pravastatin and rosuvastatin, have demonstrated significantly less effect on cognition in comparative studies. If experiencing brain fog or memory issues while on a statin, patients should ask their doctor if switching to a hydrophilic statin might provide similar cardiovascular benefits with less cognitive risk. It is also important to have CoQ10 levels checked, as statins deplete this vital compound necessary for cellular energy in the brain. Medication number 4 on our list is amitriptyline, an older tricyclic antidepressant often repurposed for conditions seemingly unrelated to mental health, such as chronic pain, nerve pain, fibromyalgia, and migraine prevention. Doctors often prescribe it for its sedating side effect to help patients sleep. However, amitriptyline is profoundly anticholinergic, one of the most potent medications still in common use in this category. Its affinity for muscarinic receptors, the sites where acetylcholine performs its function, is extremely high, exceeding that of many drugs specifically developed for bladder control or allergies. A significant 2015 study in JAMA Internal Medicine examined over 3,400 adults aged 65 and older over a decade and found that high cumulative anticholinergic exposure, largely driven by drugs like amitriptyline, increased the risk of dementia by 54%. The study further found that the damage wasn't necessarily dose-dependent in a dramatic fashion. Even low, steady doses over years created a significant cumulative burden. The damage caused by amitriptyline is often insidious and invisible, manifesting as word-finding difficulties, sequencing problems, and a general inability to hold complex thoughts. These symptoms are frequently dismissed as normal aging until significant decline has occurred. Safer alternatives exist for nerve pain, such as duloxetine, Cymbalta, or gabapentin, which carry a significantly lower anticholinergic burden. For sleep, very low doses of doxepin possess a more favorable receptor profile than amitriptyline, and modern SSRIs like sertraline are safer for mood management in aging brains. Medication number 3 focuses on antipsychotics, a category where serious ethical concerns intersect with cognitive risk. Antipsychotics were originally developed for severe psychiatric conditions like schizophrenia and bipolar disorder with psychosis. They are powerful brain-altering drugs with significant side effect profiles. However, they are routinely prescribed off-label to elderly patients who display confusion, restlessness, agitation, or difficult to manage behaviours in long-term care facilities. The tragic reality is that these medications are often used for the convenience of short-staffed caregiving environments rather than for the patient's benefit. The FDA issued a black box warning over a decade ago about the increased risk of death in elderly patients with dementia-related behaviours when given antipsychotics. The neurological damage arises because these drugs suppress dopamine, a neurotransmitter linked to motivation, reward, movement, and executive function. When dopamine is chronically suppressed in an aging brain, patients experience flattened emotions, slowed thinking, impaired memory consolidation, and accelerated neurodegeneration. A 2022 study in The Lancet Healthy Longevity, tracking over 25,000 older adults, found that seniors given antipsychotics for behavioural symptoms were 71% more likely to experience worsening cognitive decline within 12 months, even if they had no prior dementia diagnosis. Families with loved ones in care facilities or individuals prescribed quetiapine or risperidone for non-psychotic reasons must ask direct questions about the necessity of the drug and inquire about non-pharmaceutical behavioural interventions that have been attempted first. Medication number 2 is paroxetine, Paxil, an SSRI antidepressant that, unlike its counterparts like Zoloft and Lexapro, has a significant anticholinergic profile. When a patient hears SSRI, they typically assume it's a modern, well-tolerated antidepressant, and for most drugs in this class, this assumption holds true. Paroxetine, however, is the exception. Its unique pharmacological structure gives it significant anticholinergic activity that interferes with acetylcholine in a manner much more similar to older tricyclic antidepressants. A comprehensive 2021 review in Frontiers in Psychiatry found that elderly patients taking paroxetine experienced measurable declines in verbal recall and short-term memory within the first year of treatment, effects not observed in patients taking other SSRIs. The American Geriatric Society recognizes this specific risk by including paroxetine on its Beers criteria, an official list of medications considered potentially inappropriate for older adults, precisely because of its cognitive side effects. The irony is that paroxetine is often prescribed to older adults for anxiety and depression, the very population most vulnerable to its cognitive impact. The fix in many cases is straightforward. Patients over 60 taking Paxil should ask their physician about switching to sertraline, escitalopram, or another SSRI that offers equivalent antidepressant benefits without the significant anticholinergic cognitive burden. Finally, we arrive at medication number 1, anticholinergic polypharmacy. This is the hidden pattern that ties all the previous examples together and presents the single greatest risk of drug-induced dementia. While a single medication on this list might cause only mild, barely noticeable brain fog, the real-world scenario involves seniors taking multiple prescriptions and over-the-counter drugs simultaneously. The average American over 65 takes 4 or more prescription medications daily, often prescribed by different doctors who lack full visibility into each other's prescriptions. When several of these medications possess anticholinergic properties, their effects do not just add up, they multiply. A 2022 analysis in Age and Aging tracked over 280,000 older adults and found that those with the highest anticholinergic burden, calculated using a validated scoring tool called the Anticholinergic Cognitive Burden, ACB, scale, had a 120% increased risk of developing dementia over a 10-year period. This risk is doubled for patients taking pills they were never warned about in terms of cognitive impact. Consider the hypothetical case of Dorothy. She takes Benadryl PM every night for sleep, oxybutynin for bladder control, amitriptyline for nerve pain, and an over-the-counter heartburn pill, which may contain anticholinergics or cause B12 deficiency. 3 of these medications are highly anticholinergic. Each prescriber views their prescription as safe in isolation, yet together, Dorothy's combined anticholinergic burden score reaches a level clinically associated with significant dementia risk. This phenomenon, polypharmacy, is perhaps the most underreported driver of dementia-like symptoms in the elderly population today. The good news is that drug-induced cognitive decline is often reversible. When the medication burden is identified and systematically reduced under medical supervision, many patients experience a remarkable recovery of mental clarity, memory, and personality as the cognitive fog lifts. The brain is adaptive and capable of healing when given the opportunity. To protect yourself or a loved one, a concrete 5-step action plan is essential. Step 1 requires writing down every single item taken, including all prescriptions, over-the-counter medications, supplements, and occasional sleep aids or allergy pills. Step 2 involves looking up each item on the Anticholinergic Cognitive Burden, ACB scale, a free tool available online that scores medications based on their risk level. Step 3 is scheduling a medication review with a primary care physician, explicitly stating a desire to assess the anticholinergic burden. A good physician will appreciate this proactive approach. Step 4, ask specifically about deprescribing, which is the legitimate and growing medical practice of systematically tapering off medications that are no longer necessary or pose unacceptable risks. Step 5, if a doctor dismisses these concerns, seek a second opinion from another physician or a geriatric pharmacist, a specialist specifically trained in performing comprehensive medication reviews. It is vital to understand that symptoms of memory loss, brain fog, or confusion are not inevitable aspects of aging. They may be side effects of a medication or combination of medications. By taking control of this information, patients have the tools to protect their brain health and ensure their later years are not defined by preventable cognitive decline.